So I think we can get started. Just to do a couple quick introductions. My name is Natalia. I'm one of the co-chairs of the Women in Science group and part of the LGBTQ+ subcommittee. And then we also have from Women in Science as well, Matt, who's helping host with me, who is also from the Women in Science group at Martino Center and also on the LGBTQ+ subcommittee. We're both researchers at Martino Center, and then joining us today we have two wonderful clinicians from the MGH Transgender Health Center who have very kindly offered their time to talk with us today. So we have Dr. Alexis Drutchas. So she joins us from, like I said, MGH Transgender Health Program, and prior to that was over at Fenway Health in Boston, which is a provider of specifically healthcare for LGBTQ+ populations. And she's both at the MGH Transgender Health Program now and also an attending physician at the MGH Division of Palliative Care and Geriatrics. And then we also have Melanie Cohn-Hopwood, who is a licensed clinical social worker, and she's been working at MGH for the past 7.5 years and with the Trans Health Program since its inception. And she also worked at the Fenway Health Program as well before then, as well as working with people living with HIV at the Boston Living Center. So they both have quite a lot of experience in this area, and I'm very grateful that they've joined us today to help share this information. So just for everybody who's watching, if you want to pop questions into the Q&A, let me just do that whenever you want, and we'll try to address questions as they come up, and then anything that isn't covered by the end, we'll take another 10 minutes or so at the end to see if there are any additional questions from the audience. So if something is a little confusing, you want a little clarification on something that our speakers are talking about, then please don't hesitate to put those questions out there. And so without any further ado, I'd like to turn it over to our speakers.
Great, thank you so much. Welcome everyone. Again, thank you for having us here today. And as Natalia said, please use the chat box, because if you have a question about something, most likely other people do as well. We want everyone to be kind of on the same page. We're going to go over some basic information because we know that there are people coming from all different backgrounds and experience levels when it comes to LGBTQ, working with LGBTQ individuals. And so we want to make sure everyone has the same language and the same understanding when we are talking about things a little further into the training. So that's it. Alexis, if you want to
next slide
move forward.
Just see if let me make sure. Okay, we don't have we're not getting paid by anyone in particular that we need to tell you about as a disclosure.
Great. So at the end, everyone will hopefully understand gender terminology and pronouns, understand sexual orientation terminology and the difference between the two, appreciate how this language can be used in data gathering and research, recognize steps to take to increase inclusive language in your work and workplace, and hopefully reflect on initiatives that can be taken to improve competency in research across everyone's different projects. So to get started off with, why is this important? This image here shows kind of an estimate of the population of LGBTQ people in the United States, and understanding that this is from people's self-report. And so the likelihood that there are much higher numbers of people who identify as LGBT is because not everyone will tell a surveyor, right, how they identify. But as we know from this study, at least the state of Massachusetts had this one of the second highest rate of people who identify as LGBT at 4.4%. And Alexis, if you want to go to the next slide, you can see again here across the 50 states, Vermont only surpassed Massachusetts in people who self-identify as LGBT.
I think another thing here to recognize is the experiences that some, not everyone, but many people have in the healthcare setting. And often when we think about scientific research and healthcare, in a lot of our minds, they're sort of hand in hand or they go similarly. And so I think this survey, which came out in 2015, it had people in every single state on it, so rural, also urban areas too. It really shows that there's still, even in 2015, a lot of discrimination in care. So something to look at is this idea that I think the figure on the right, 7.6, that 23% of overall respondents said that they didn't seek healthcare because they were worried about some kind of mistreatment there. And I can tell you from working at Fenway, anecdotally, we had a lot of patients that sort of switched care because of mistreatment in care. So just anecdotally, even in Boston, which is a large urban area, people still felt like they were getting, not great care in many different ways. So again, I think just understanding the why is this important is because you as like in your research work can, I think, do a lot to uplift and make a lot of these experiences better. But it's also important to know what people are still holding on to so that you can recognize and sort of help to make things better in the future. So gender identity is something probably everyone has heard of, but it's really important to be super explicit as we move forward because often there's a lot of misunderstandings between the differences between gender and also sexuality. So sex assigned at birth is based on genitalia. It's in the movies where a baby is held up, someone says it's a boy, it's a girl. That's just based on the physical characteristics of someone's genitalia, whereas someone's gender identity has to do with their internal sense of gender. Do I consider myself male, female? Do I consider myself non-binary? Am I questioning? All of that has to do with your gender, like your overall identity, your internal sense of identity. That might not be the same as someone's presentation of their gender, how someone looks, their hairstyle, all their mannerisms, that goes into gender presentation. That might not necessarily go with what you see or think their internal gender identity is. So it's important just to recognize those can be different or seem different. Also, these change or evolve over time. I'm sure Melanie and I have had patients who, we see early in life, some that I saw well into their 70s or 80s, right? And so things can shift and evolve, and that's really important. Just because someone is in your research in their 20s and they come back and do an intake at 35 doesn't mean the questions are going to be answered exactly the same. I think as we know, how we feel about ourselves change, and that goes with all the people coming in for your work as well. Cisgender, transgender, these are terms that we often hear. So cisgender is that your sex assigned at birth is congruent with your internal identity, versus trans is that your sex assigned at birth isn't the same as how you feel about your internal gender identity. Again, transgender is a large umbrella term. It can encompass being trans female, trans male, non-binary, gender non-conforming, agender. So transgender is a large umbrella term. It doesn't necessarily say how a particular person feels about their own gender identity. So just know it's sort of an encapsulating umbrella term. It's important to recognize, and I actually just read something recently, that X is now allowed on driver's license. I'm forgetting what state passed that, but especially, so something just to be aware of, that can be something that you see on driver's license moving forward.
A few states actually, including Massachusetts, have that now. And so as more and more states adopt it, they're going to see it more often as people travel around the country. The Massachusetts just started within the last couple of months. And so not many people have it now, but medical record system, actually, they're updating this week to include gender identity as X, so that gender as X, so that when people have access to their medical record, they can list what's on their ID. So this is a gender unicorn. Oh, did you have a question, Natalia?
I was just going to mention, I don't know if anybody listening does this kind of research, but if you're pulling information from medical records, from Epic, you might start to see that change yourself in your research. And so that's also something to be aware of, that's happening now.
Yeah, thank you. And also a lot of these different terms that Alexis mentioned are things that people can choose, how they self-identify. So that is also listed in the chart, but not for everybody. Not everyone wants it in their medical record, because this is also information that gets passed along from one place to the next, and it's not always safe for everyone to do that. So depending on the individual and their circumstances, it's always good to still ask people how they identify, even if you do access their record. Gender unicorn is a little tool that we use sometimes to describe the different terms that Alexis was talking about, but also as a way to understand that it's not just male or female, it's not just, non-binary in the middle. There's a wide range of ways of being. So the gender identity, the rainbow, is the, how you know yourself to be. It could be feminine, it could be masculine, it could be a little bit of both. So if you think of this as kind of like a slide rule abacus or something that goes back and forth, maybe one day your gender identity is feeling more towards the pointy part of the feminine arrow, and maybe more towards the left side of the male or the other gender's arrows. It could be then slided another day, slightly different, or as time goes on, as you know yourself better, that can change. These are not things that are fixed in time. Gender expression, again, the things that how you present yourself to the world. A lot of people don't present themselves as a gender they identify with, at least initially, because of safety reasons. And we have a number of patients who come to us and say, I'm gonna, change my name and officially, get everything moving forward and how I present myself to the world once I have been on medication and I know that I can, feel more affirmed in my body and appear more the way that I know myself to be. Sex assigned at birth, the little DNA symbol down at the bottom. Again, that's the only thing that is not really changeable. But we also include intersex here because that's not always put on birth certificates or anything like that. You're kind of forced to choose a male or female. The gender X also allows people who are intersex to have that on birth certificates. But again, it's only very few places that are doing that. And actually, I don't know if Massachusetts does that on birth certificates or just driver's licenses. So that's something I don't even know. And then who you're physically attracted to, who you're emotionally attracted to, those are not always the same as well. So friends, partners might be, different. And it's not always necessarily men, women. It might be femininity, masculinity, androgyny, the things that attract you. So that's kind of a general way to think more broadly about the unicorn. The next slide is about pronouns. So when I introduce myself, I often will say, my name is Melanie Cohn-Hopwood, and my pronouns are she, her, hers. And when I do that, it's normalizing for other people, and it's also making them kind of aware that I'm thinking about pronouns as something that is a part of people's identity, and it may not always match up with how they appear to the world. So when I then ask them, what pronouns do you use? It's a lot more comfortable than just asking someone off the bat what their pronouns are. So there's a lot of different ways that people are identifying themselves. And pronouns are something that are actually very important to people who are trans and non-binary. These are things, that can change over time. Some people, who are binary identified, but trans will use male or female. And that's how they identify. Some people who are non-binary might use they. I've had patients who only want to use their first name. They don't want to use any pronouns at all. I've had people who will alternate, like male one, one, female the other. And also there are other ones that are less common, not heard about, but becoming more popular are they, them, which is as a singular rather than as a plural pronoun. So instead of me saying, my name is Melanie and my pronouns are she, her, hers, I would say my pronouns are they, them, theirs, but still referring to me as an individual, not as a group of people. And then Z, zir, C, seer, there's lots of different ways that people are trying to create new ways of addressing people that's not stuck with this male-female dichotomy. And some things to think about, like on the little poster on the side here, is that the language that we use is often very gendered. And it's a subconscious thing. That's kind of what we're conditioned to do. And it's good to be mindful of this. I do this myself. I constantly tell my kids, hey guys, let's go. And, then I'm like, oh, why do I keep saying guys? That's just something I grew up with. But trying to be conscious of the language I use, thinking of something, that's more gender neutral, that doesn't identify everyone as guys or gals or whatever, is really much more affirming and inclusive. So when you think about ladies and gentlemen, saying distinguished guests, who's that person over there? Everyone, let's go to the store. So there's different ways of thinking about the language that you use that is still normalizing and is affirming without having to assume someone's gender and potentially call them by the wrong gender pronouns, which is very upsetting and very discouraging for people.
Mhm.
Go ahead.
I think too, what often we get asked, or I've been asked before, is what about older individuals? This might feel very new for them. Am I going to alienate people or confuse people by asking? I think, I'm a palliative care physician in the hospital, which is a very different hat from this work. But I've been really trying to, when I introduce myself, say I use she, her, and, what name should I use for you? What pronouns do you use? And you do get some blank stares of like, what are you talking about? And then you have to explain. But I would say the awkwardness of that with certain people pales in comparison to how much comfort and affirmation you give people when they need that, right? So I would just say that while it might seem hard or awkward for some people coming in that you're doing intakes for, whatever, for your research work, I think it could be super helpful and affirming for those that, you ask and they're like, thank you for asking. I use they, them, or I use she, her. I think it can really be of benefit.
It's also a way to assume that, to not assume, sorry, that what people's pronouns are is, to ask them what name they use is much more common. And so if you just tag on to that, what pronouns do you use? It becomes more natural the more you do it, but it can be awkward at first. I started identifying myself that way most of the time now when I talk to people on the phone or wherever I go. That has nothing to do with my transgender health work. It's just something that's become more ingrained because I've been doing it a lot, but it took me a long time to get to that comfort level of that.
Mm-hmm. And not to harp on this too much, but I think we'll get back to it in the future of how to make the workplace feel more inclusive, how to make intake forms more inclusive. I don't want to say this is an easy place to start because it does take a reframe, but in comparison to other changes, I do think this is a really easy, very important place to start. And so we'll talk about that more, about sort of how to change the work environment and intake forms. So I'm just going to touch briefly on sexual orientation. Again, this is just to get everyone on the same page. So sexual orientation can mean a lot of things, but mostly we think about who am I attracted to? Who am I romantically interested in? Who am I, attracted to in all different ways, in all different planes, emotional attraction, romantic attraction, sexual attraction. This can be fluid. This can change. So a lot like gender, it's not just stagnant in time. It can shift and change over time. And it's not necessarily the same as overall sexual behavior. So just because someone might identify as straight or gay doesn't mean that that's always in line with their sexual behaviors. Heteronormativity is the assumption that all people are straight or heterosexual until proven otherwise. I think that comes back to a lot of our language and our intake forms of just assuming, what's your husband's name? Like really like small things that we say all the time is within, I think, our heteronormative culture, that we assume people are in a relationship with someone who identifies as the, opposite gender. And that I think could be a really helpful place, again, to reframe in the workplace and on intake forms. So gay, how we think about gay is that a man who is predominantly, attracted to men, exclusively attracted to men in relationships with men. I will say, I think a lot of women also use this term. I feel like lesbian, although it's, the term used for women who are attracted to women, women who have relationships with women. I think anecdotally, I just don't hear it as much among friends and among patients as women using the term gay. So I think for many people, it's just a word to say that you're attracted to someone with the same gender identity or as you. I would just say that's an easy way to think about it. Sexual orientation continued. Bisexual is a person who's attracted to men and women. I think it's much more of a binary term versus pansexual or queer in many ways, that you're sort of attracted to the person regardless of their gender identity. I think queer is a really good term to just become familiar with because it's used so much more often. I think you see it in writing and in media and in press. I think it's, taking and reclaiming a term back that used to be used as a very hurtful term. And now is a term, I think, to describe sort of a relationship that's different than heteronormativity. It's sort of saying, I don't identify in that heteronormativity bubble, and my relationships or my sense of self isn't on the binary. And I think it's too like has sort of an advocacy type of like slant to it in a certain way. Asexual is a person who does not feel sexually attracted or desire a sexual partner. That does not mean they're not in a relationship. It just means that the sexual part isn't necessarily what they're looking for in a relationship.
So there's lots of different ways that we communicate. Some of it's visual, and some of it's the questions we ask, and some of it's, you know, how we ask things. And oh, someone saying they'd like to add aromantic as a pertinent term, and you're right. There are people who identify as aromantic who are not interested in, you know, romantic relationships. There's lots of different identities that we didn't include here, but we're happy to you can come up with lists of more if people want to know more ways to be affirming, and the paperwork that you offer folks to have more. We'll talk a little bit more about like ways to have more inclusive forms and things as well, with more options for folks. So thank you for that. So initial experiences matter. I think the physical environment when you walk in the door, nowadays with COVID, we're all on Zoom, but also the words that people use, all of these things impact us, the forms that people fill in. You know, I've had my kids go in for studies at the Charlestown Navy Yard. I forced my kids to do research studies. It was great. Some way to kill time, and they loved doing it, and they got money to buy things with. So worked out for all of us. But you look at these forms and they're very binary. They're also sometimes like copied from 20 million years ago. And there's only male, female. The choices don't always fill in all the identities that my family has, that other people's families have. So when you look at these forms, you feel automatically excluded. So any little clue like that, even like posters on the wall, the magazines that are in the waiting room, you know how thoughtful people are and inclusive they are when their space has, you know, any little like a rainbow symbol or, you know, trans flag, or the flag that was on the last slide that had the arrow in it, which is like trans and people of color inclusive pride flag. So the unity flag, these symbols are little ways to hint at folks that you're inclusive. Your badge could have we often have like little ribbons on them, or a button with your pronouns on it even. A number of people have those on, so when they go into inpatient units, the social workers, that they don't even have to introduce their pronouns, people can see it right there on their badge. And those are all hints and ways that you can make your place more affirming and supportive of all people. Things like single occupancy restrooms, or gender neutral restrooms are not always available, and people who are not on the binary don't feel safe necessarily having to choose a male or female bathroom. So what do? Not use the restroom or risk being attacked or harmed. This fear around bathrooms is really, there have never, to my knowledge, been anyone attacked in a bathroom because a trans person attacked them. It was because people who are trans have been attacked in restrooms. And so it can be a very unsafe place. So having gender neutral or single stall bathrooms is really affirming way to have just an environment that's welcoming and inclusive.
And I would just add to that, to be aware of where those are located and make sure that you point them out to people when they enter the center, because they might not necessarily, you know, be as familiar with it as we are, and it's an easy thing to forget. And I think people can be a little shy about asking as well. And then we also had one great question about the word queer. So just going back to what you were both talking about before. So given that its derogatory history, in what circumstances is it appropriate to use? Is it only as a person who's identifying as queer, or as a heterosexual person referring to a person, whether that's a patient or volunteer or a friend, who is queer? So what are those circumstances where you might want to use that or might want to avoid it?
Yeah, Alexis can talk to this too, but I feel that it very much relies on the person's self-identity. So some of it is if you're asking someone how they identify, you're filling in a form, or you give them a form to fill in. If it's not on there, or if there's no like write-in option, you're not going to know how they identify. And I wouldn't call someone queer if they checked off gay or lesbian. But if you interview someone and you ask them, or you have it on the form and it's an option and they say identify as queer, then it's okay to use that with them. But I wouldn't volunteer it because it can be seen as offensive. The other thought to that is if you feel uncomfortable using that term, it's also okay to say, I know this is how you identify. I feel uncomfortable using this term. Is it okay if I use a different one? Or, I apologize in advance if I stumble over the word. But, to be aware of it. My boss did that in an interview. There was a person we hired who had, queer this, I'm a queer that. And my boss was like, I have a really hard time with that word. And so it was fine, as long as you acknowledge it. I think that's really helpful. Alexis, did you want to say anything about that either?
I would echo everything you said.
Yeah, cool. So this is an example, these are a couple examples of intake forms. There's lots of affirming forms out there that you can Google if you're looking to find a way to make yours just more inclusive. It could just be as simple as an open blank, write in how you identify, what's your pronouns, what is your gender identity, what's your sexual orientation. Or you could have a bullet point with, multiple options. The medical record system, for example, allows people to enter their own identity. If you have a MGH record, you can try it out yourself and see how it works. I put mine in there and I went and had a procedure, and I even had my name as Mel instead of Melanie because I was playing around with it. And I'm like, I'm gonna put a preferred name in there, why not? And people had a really hard time calling me Mel, which I think is a pretty, surprising kind of name. It, could be gender neutral. It could be, but some people called me Melanie and some people called me Mel, which was fine with me. But if I was transgender and Mel was how I identified and people called me Melanie, that would be really harmful and just completely, it could be devastating. So going in for this procedure, I'm very vulnerable. I'm about to have an operation and someone calls me the wrong name. Or refers to me with the wrong pronouns, just think about how that might be. So again, as you're addressing people, you're not doing an operation, thankfully, but to be affirming, having these options available really makes a difference. So if you put that into your own record, see how people address you if things are a little bit different, or if not, if they get ignored.
And I think something with this that we'll come back to as we talk about how to sort of elevate all of your research endeavors is that I totally can understand on the research end, there's a lot more work that goes into having more boxes, right? When you're sifting through all of your data, it takes more. I'm sure there's more columns in there when you have, many different columns of how someone, about their pronouns, about their gender. But I think if you're able to do that and capture some of that nuance, you would be able to put a lot more into the research world that we're just not seeing. And I think that, that would be really an important add that you could do. Right now, so much of research is in the binary male, female. And so I think with a little legwork early on to be able to adapt and add this data, you could add a lot to our world of research and also to help patients feel included in the research world too. So taking an inclusive history, I think, this might be more clinically based, but I want to talk to you about sort of ways that you might be interacting with people at the center. But I think something that, just to go back to pronouns and all of that we, to loop back in now, is using overall neutral language is best until you know what a patient uses. So instead of saying, I could imagine someone's waiting, they're coming back to the MRI, instead of saying, sir, come with me, you use just their preferred name. And then you ask about pronouns and then you tell them yours and then you bring them back. It might take a few extra steps and you might stumble at first, but I think having staff and having that first interaction go well and be affirming is really, really important, I think, to help people feel safe. Recognize your biases. I think thinking kind of through some of those earlier definitions, the fact that a lot of people aren't out, that they might not present the way they feel. They might not use the name with you that they use at home or with a partner or with friends. We certainly have a lot of patients who say, I'm going by they, them with my best friend, but I haven't told family yet. So I think we just have to recognize that we might have biases based on when we look at a person, right? We take a snapshot with our minds. We say, this is what I think they are. And our brains do that without us even thinking in a second. But I think pausing for a moment when you're about to meet someone, recognize your assumptions and step back and sort of go through sort of name and pronouns and all of that will be extremely helpful as you sort of reframe some of this. I think assuring confidentiality in your research, if you are gathering data about gender, about sexual orientation, just assuring that it's confidential, knowing that not everyone is out in different spaces. Recognizing that some people might still be under their parents' insurance, right? So being sure to tell them what's confidential and what's not is really important. And then I think the biggest thing here that Mel and I were talking about is asking or not asking, telling people why you're asking. So for example, if you're, it's an MRI study and it wouldn't be safe for someone to be pregnant. Asking them, saying it wouldn't be safe for someone to be pregnant. So I'm going to be asking you a bit more about gender and about the possibility that you could be pregnant. Is that okay? I think all of those, again, they take a few extra steps of consciousness there, but super helpful rather than just assuming and saying leading things like, you can't be pregnant, right? If you have someone who seems male in front of you, or any chance you could be pregnant, when it's someone who appears female. I think asking why and then stating open-ended questions are a really great way to make sure that you're more inclusive. And again, that you're helping people to feel safe.
Thanks. So there's a question about trans and non-binary identities in the term woman, and whether or not they are, people who are non-binary are okay with being connected with people who are women kind of as a group per se, or if you should separate the terms. And I would say definitely separate the terms. The question kind of assumes actually that all non-binary people are assigned female at birth. So people who are assigned female at birth are more assumed to be feminine, even if they identify to be non-binary or transgender as well. The people who are assigned male at birth who are non-binary are out there. And you may or may not realize it when you look at somebody, what their assigned sex is, and also how they identify. So again, it's really important just to ask and to separate out the distinction. So when you're talking about men, women, people who are non-binary or transgender, we even say trans and non-binary or gender expansive. There's lots of different terms to use that can be more inclusive without necessarily having to lump people together. One thing that came up for me a lot in the HIV world is the research on men who have sex with men. So in the HIV prevention world, we're trying to prevent HIV spread between people having anal sex. So they lump people who are gay or who are men who are straight but have sex with other men into the same group as transgender women. They're women. And by saying they're part of this men who have sex with men, we're affirming them as not being female. It's not, we're saying we don't see them as being women. And if the research is really about how do we prevent HIV transmission during anal sex, then that's the research. We can find other ways to word that than MSM and assuming that all trans women are part of that population. If we're studying people who are having sex, men who have sex with men, you can then ferret out the information between what are there higher risks or different risks for people who are trans identified? Are there different risks for transgender men who are having sex with men? Who are also sometimes included, sometimes excluded. So really being specific about who's included, who's not included, and then using that research to help this population have more information out there, to have more publications that are even addressing these issues is really important because, it's a growing field, and we'll talk more about research in a little bit, but again, just thinking about ways to be inclusive, I would list more names rather than try to lump people together. That's my long version.
Yeah, and just to clarify for the person who asked and also for anyone who couldn't see it typed out, the term they were asking about was women with an X. So it's sort of, I think, meant to be a slightly more inclusive term, and there are people who use it, but it sounds like the best move is to separate out those groups rather than automatically lumping people together, and affirm the identity that they kind of hold most strongly.
Yeah.
Yeah.
And I can imagine in the research world, if your N isn't large enough for any one group, especially as you start out and you're trying to recruit people and maybe you don't have as many people who identify in certain ways, I could imagine in data, you could put, all people who are under the trans umbrella together, but then you would have to be very explicit. These are the percentages of people that we've put together here to sort of make your N bigger, right? But I think being really inclusive when you're gathering the data and at least sifting it out, as Mel said, would be really important.
Yeah, a number of people who are, just again, back to the non-binary thing. Sorry, I hope I'm not perseverating too much on this. Is that it's really about asking people how they identify. And so when you have a term that sounds, women with the X sounds and feels more like you're assuming people are female, or you're lumping them in with this group, and people who are non-binary may or may not feel comfortable with that. So rather than kind of make that lump, I think there are a lot of non-binary people who I've seen who are like, I'm non-binary transmasculine, or I'm non-binary transfeminine. And to be lumped in with people who are more binary would be very uncomfortable and not feel affirming.
And then we also had one more question from Laura. So
yeah.
I've heard some clinicians at transgender centers use an organ inventory to determine what care might be necessary without impinging on gender identity. Have you heard of this practice?
Mm-hmm. I think at Fenway, they started to use it during my last year there to sort of, for that same reason, right? When you're thinking about a lot of times, like what kind of cancer screening do patients need? An organ inventory is really important. So I think health centers are using it much more now. I could imagine that in the research world, that could be interesting. We'd have to think more about that on an intake form, so that you would sort of know beforehand if safety issues around certain, like if it's a pharmacy study or an MRI study, and then you have a sense then of what you need to worry about, that doesn't force a patient to, check a box off. I think that could be sort of an interesting new way to do things. I don't know, Mel, how you feel. It feels like both are important. I feel like I wouldn't want to exclude someone's identity, only because so much in the research world, it's still so binary of male, female, unless you're specifically looking at LGBT research. And so to me, it feels really important to be inclusive of of all different identities, but the organ inventory for safety feels like it could be helpful.
Yeah, definitely. And, if you're doing research on prostates, if you advertise for anyone with a prostate, you'll naturally include trans women who haven't had it removed for medical reasons, for cancer. So having an organ inventory can be very helpful, because those organs need to be treated and monitored as well for the medical side of things. So I'm aware of the time, and I know I talk a lot, so I'm gonna try to move along if that's okay. As far as communication goes, so as we were talking about before, trying to be more open-ended in the questions that you use, instead of saying like, are you male or female, saying, what gender do you identify with? Instead of having like tick boxes, to like have an open space for people to write in, so if they don't identify with any of the other things, they can have their own identity included. Listen to how people, identify themselves, their family members, and use that language back. So some questions not to ask on the next slide. A lot of times we are curious and we're interested and we want to know more about people. But if you think about the fact that you're asking about people's bodies, you're asking about people's very personal lives, and these are often folks who have experienced a lot of discrimination and harassment for who they are. So some questions that might seem pretty harmless actually could be very upsetting. So things like, have you had the surgery? What was your birth name? Are you married? Are you on birth control? Have you always had sex with men or women? Like, you look so great. I would never have known you were trans. There's a lot of different comments and things that you may feel are affirming, but I can tell you that they're not. So think about what you're asking and why you're asking before you ask something.
I think this is an important one to point out. What if I make a mistake? I think surely all of us have fumbled through this. I certainly have before. And our goal is to make our colleagues as we work with and our patients, I'm not sure in the research world if you use patients, clients, research participants, but I think our goal is to make everyone feel affirmed and safe and inclusive in the work. And so I think the biggest thing is just to recognize it was a mistake, and say you're sorry and correct it in real time. I think even if it feels awkward, even if you're ashamed you did it, I think taking the time to do that is really helpful. Even just saying, I'm so sorry I used the wrong name. I'm so sorry I didn't ask you about your pronouns and I made an assumption. Melanie and I were talking about how easy it feels to sort of start to ramble after that. I'm so sorry I did that. I won't do it again. I'll be more careful. I think none of that feels as important as just saying, I'm really sorry I didn't look at your pronouns before I called you back to the back to the MRI scanner or what have you. I think just correcting that, also doing that in front of colleagues so they know that that's not okay and this is the environment that is important to you at work, is also really, really, I think, an important practice moving forward.
So in thinking about research, as I said, like the MSM, don't lump people together. Please try to specify who exactly it is that you want to research on. So if you only want to research people who are in one particular category, list specifically what the thing is that you're looking for. We had a question earlier about when writing for publication, like how do you acknowledge basically that maybe your research is looking at a binary male-female dichotomy and you know that there's more genders out there, that you don't have the ability, the resources, the numbers of patients to be able to extrapolate the data on that. So the more you include these kind of reflections, it's the more that it allows future researchers to say, oh, yeah. And it also shows that you're thinking about this and you're affirming that there are more identities. And so for future, in the future, there's, you have to be able to say what your limitations are, but it also acknowledges that you are competent and you're aware that you're limiting what you're looking at. There were a couple other things would make a huge difference if different genders were included in outcomes, not excluded. So even if you have a few people who are trans and non-binary, you can't maybe extrapolate the research data to them as much. It might help to, to still comment on some of that data as well if you do have it available to you.
Mm-hmm. I think too, thinking about, the supervisory structure, when you go to the IRB, when you go to your PI and talk about the next project you're working on or a current project, this is something you could bring up, in talking about, I think we need to be able to recruit a broader, a broader group of people. These are the things I'm thinking about. We were talking about, is this something you could bring to your supervisors who might not have this on their radar, or bring to the IRB to say, in the future, when you're looking at people's research projects, this is something that they should really include if we're going to move forward, if you're going to if the IRB is going to be sort of okayed. So that's just something to think about as a way to advocate and sort of move the whole center forward.
And I can see it as somebody that has looked for this kind of research. A lot of what you find when you search for research on transgender and other gender expansive individuals is a lot of research on why people are trans, or what the differences are between transgender. Is it brain differences, and what are the hormonal differences, things like that really investigate the transness itself. But they have, trans people like everybody else have all kinds of other medical concerns that have nothing to do with that, but maybe a lot more limited information from the research about maybe what that disease process looks like in somebody like them with their body, versus, somebody that's cisgender. So it's not, even if you're not particularly interested in that question of, why people are trans, there's tremendous amount of research to be done just for that population as a whole, on every other issue that touches humans.
I completely agree. I think when you do a PubMed search, I think the biggest things that come up are, research on hormones, HIV research, STI research. Clearly these are important, but I think it feels really degrading as someone in that population that this is where it's centered, right? And I think moving away from that and making sure that gender expansiveness, sexual orientation expansiveness is included, and that when it's not, you say, we realize it's not, and this is what we're working on, I think would send a really large message to the community as well, to the medical community, to the research community, that this matters and we need to sort of change and elevate ourselves with the times too.
Yeah, if you're looking for more research opportunities, it's also great to have focus groups of community members, to look at the study, the National Transgender Study from the US, and see where are the areas that really need help, whether it's depression rates, whether, there are other things that are super important and super needed. And so getting from the community those ideas too about what would be most helpful is a great way to start if you want some more expansive research options.
Mm-hmm. And certainly being in the Northeast, there's tons of groups. And I think now that a lot of things are all on Zoom, it's a lot easier to get people together to ask some of those questions. And certainly if people have certain interests, we could be an overall resource for you to say like, oh, if you're interested in aging LGBT individuals, here are a few groups you could think about reaching out to, just as an example.
Yeah. Another question just came in about asking about pronouns. So I just want to, reiterate that please ask people what pronoun they use. I will try to remember as much as I can to introduce myself with my name and my pronouns. I also put it in my signature, in my email. They can find different ways to make it visible so that people see it. I even have a little link on my email signature that's to a pronoun information guide that explains why pronouns are important. So please ask people about what pronouns are whether it's in your intake forms, whether it's face-to-face. Even Alexis had kind of referenced earlier, if somebody comes back again, their pronouns might have changed. We see it often. And so again, we have a particular population, but that doesn't mean that the people that you think are cisgender aren't actually transgender, or maybe they discover that or come out about that later on. So thank you for asking that. The next slide is, I think about, so creating a affirming workspace. The kind of the basic for that is, everything that we've talked about before as far as research goes applies as well here. If you have a coworker who is trans or non-binary and they come out to you, thank them for letting you know, and ask them if there's any way that you can support them in being in this environment and making it more friendly and welcoming for them. Everything else again, applies, if they're not fully out at work, be thoughtful about how you refer to them and who's around you when you talk with them.
Yeah, I would just echo on that I think it's, really easy on a Zoom call now because we're not around the water cooler at the lunch area together, but I've certainly had colleagues who you're chatting before the group starts and they reference something that you had talked about privately, right? I think you need to be very careful of this when it has to do with something that someone has shared with you. And I think in our Zoom world of not always seeing who's on the call, who's not, it's just ever more important to check in about because some people are only opening up to, certain people first. Or just work and not at home, just home and not at work. And I think it's really important to recognize those boundaries and ask. Increasing your knowledge. I think there are so many resources online now through the Fenway Institute, through the Center for Excellence in Transgender Health. WPATH is a large international organization. So there are many places if you're looking to learn more that you can go to online that have like very easy to access sort of overall PDF files that you can look through if this is something that you're interested in. And I think while these might be more health centered, a lot of some of the language and the things to learn, I think would be very applicable to your work too, especially as you're thinking through like the overall work environment, intake forms and things like that. I think a lot of that is talked about, at least in the initial parts of these resource guides.
There's also in the LGBT Health Education Center, a number of, if you're not a medical doctor, you don't get CMEs, but a lot of great trainings that are available for free on their website, including frontline desk staff, trainings for how they can introduce people, how to ask questions, for it, which would be applicable to the work that you're doing as well. So definitely the Fenway it's based out of Fenway, it's the LGBTQ+ Health Education Center.
So I know we've talked about a lot this evening. There's a few closing thoughts of things we hope you take away, that sex is sort of the sex assigned at birth and is related to one's genitalia, whereas gender is someone's internal sense of who they are. Sexual orientation as it relates to their overall relationships, to their but it's not necessarily related to one's behavior. So someone might identify not in the same way as their like sexual activities are. So start by asking questions that don't assume an individual's, don't assume anything about the individual. So just like we said, I think if you can take away sharing your name and pronouns, asking people theirs, asking how they identify, using their words then in your interactions, I think that would be a great thing to take away from here.
Yeah, and using inclusive and neutral language. So again, we're trying to remember as much as possible not to say, hey guys, let's go, but like, hey everyone, let's go. I think little changes like that make a big difference. Looking for ways to improve the inclusivity and the gender affirmation in your environment, whether the bathrooms are labeled as gender neutral or not, if they are even, if it's possible, like, are there single stall bathrooms? Are there no single stall bathrooms? I don't know if you know this, but the new Partners building that they just built up recently, well, the Mass General Brigham, excuse me, in Assembly Square has zero gender neutral bathrooms. And they just spent millions of dollars on this building. So now they're trying to retrofit bathrooms in there. But these kinds of little things, they're not thought of. They're just not part of the normal discourse. But when you try to be gender affirming, sometimes we have to figure out ways to change things and make it more inclusive. Signs, marketing, brochures, the flyers that you have out, the posters on the walls, all these things make a difference. Your ID badge, if it has a little rainbow on it or not. All those things kind of are cues to people that you're welcoming and affirming. And then, if you want to know how to do things better, ask people for feedback, especially if you know that they're, gender variant, they're gender expansive, and you want to know how to make it a better, safer environment for them. It's okay to ask them, hey, I just, we'd love to know if there's other ways that we can make this more affirming for you. What did you think of this questionnaire? Should we think about changing some of the language?
And I would say, just anecdotally, I use this all the time in patient interactions, after we meet on Zoom or in person. If I've had a long talk with them, I'll say, how did that go? Is there anything I didn't ask about that's really important? Is there anything I asked about that could have been better? So I think it's a really humbling experience, but is very important for us all to get better at this. Resources, I think this states a lot of the ones that were in the pictures, and we can certainly send this out to you so you have some links if that would be helpful, of places to turn. And then we just wanted to say thank you for taking the time and being here after a long work day. We know everyone is on Zoom all the time, and we just really appreciate you taking the time to be here and learn with us.
Yeah.